Well, welcome back, everyone. Hopefully, you have stuck with me a little bit here and are continuing down our electrocardiography rabbit hole. And for this very short lesson, we're going to talk a bit about electrical vectors and the QRS complex. Still a bit nerdy, a little bit kind of mathematical, and one of those talks that, again, you can get by without this, but if you really want to understand some of the principles and findings on the ECG right from first principles, this is certainly a super useful bit to go through. And it's going to be a little bit clinically relevant, as it's going to point out to you why the QRS goes in certain directions on the ECG and why some leads look larger than others on the ECG. So we're going to start to get some clinical applicability to all of this. So here's what we're basically going to cover. We're going to talk a bit about what a vector is, and I'm no mathematician, so I'll probably butcher it a bit, but the concept anyways is going to be important. And then basically how we can use the principle of vectors to describe how our QRS complexes come out on ECGs. So remember this slide from our last talk. Just in review, let's say we're looking at lead number 1, where the negative is on the patient's right and the positive is on the patient's left. So anytime an electrical current flows towards the positive lead, our QRS, or our ECG, I should say, is going to have an upward deflection. The converse is true, that anytime the current flows towards the negative lead, we're going to have a downward deflection on our ECG tracing. Okay, so in summary, anytime the current flows towards the positive lead, the ECG is going to go up. So that's all very good when the electrical current runs parallel to our ECG lead. But what do we do in a situation like this? And in fact, this is kind of analogous to the clinical situation we get into when we look at the QRS complex and the heart, because this is actually kind of the direction that the current flows when the ventricles depolarize. So how is this going to look? Well, this is going to lead us into a concept of a vector. And so I am really likely going to butcher this concept a little bit, but the way to think about a vector is that basically a vector is a thing that can be described as the sum of its parts. I know, really deep. So if we look at the electrical current that we're describing, say, from ventricular depolarization, depicted here, we can break it into its two component parts. And the easiest way for us to do it, or to try and do it, is describe basically how far it runs from its left to right direction and how far it runs in its up and down direction, otherwise known as your X and Y axes. And we're going to use this basically as an example for the electrical depolarization of the heart, because actually when we look at a QRS complex on our cardiogram, this is actually the direction that in a normal cardiogram the QRS's electrical complex goes. Now, I know you're looking at this beautifully drawn heart and you're thinking, shouldn't it go straight down those nice blue lines, the His-Purkinje system? But actually remember that in a QRS complex, we are looking at the depolarization of the entire heart, including the muscle cells and the like. And because the left ventricle is often bigger, has more muscle mass, that the QRS kind of gets shifted up a little bit towards that left ventricle. So that's kind of the direction of our QRS depolarization. So here we are back at our problem. The QRS is being depolarized sort of from the patient's right arm area towards their left lower chest, and it's depicted by our red line. And we want to figure out what will that look like on lead 1. So we break that depolarization down into its components, the X and the Y, and then we're going to draw it out. So we begin by looking at component X. And in component X, what we notice is that the electrical current X is flowing towards the positive electrode. So what are we going to guess the ECG tracing is going to do? That's right, it's going to go up. Because remember, any time that electricity flows towards the positive electrode, our ECG tracing is going to go up. And so what happens basically with Y? Well, it's kind of funny, right? So Y doesn't flow towards the positive lead, and it doesn't flow towards the negative lead at all. So it basically does nothing. Sort of depicted like this. So basically, if it flows neither towards nor away from the positive electrode, it's not going to do anything. And so what we then do is we take the X and the Y and we add them together, and we will get what lead 1 will look like, and that's shown here. And in fact, if you look at a normal cardiogram, as we've got depicted here, lead 1 will look very much like this, with a QRS complex that is very much positive. Now, some of you astute folks will also note that there is a small negative deflection in lead 1 right at the end of the QRS complex, and we'll talk a bit about that in our next lecture when we talk about the QRS complex and the stages of depolarization. But the overall picture is that basically in lead 1, you're going to have a very positive QRS complex just because we worked out the vectors the way we did. So having said this, why don't we work out what we would expect to see in lead AVR? And if you remember, lead AVR is the one that's got this mathematical negative electrode at the heart and the positive electrode basically on the right arm. So that's our lead AVR. So we'll get rid of that beautiful picture of the heart and just leave us with the lead and the depolarization, the electrical vector we're going to work with. And again, we're going to do the same thing and break that electrical flow into an X and a Y as we see here. And when we look at it this time, we're going to ask ourselves, okay, what happens when we plot out X? Well, for lead AVR, when we look at the direction that X is going, it is going towards the negative electrode, right? And if that current flows towards the negative electrode, then basically our ECG tracing is going to go down. So for X, we're going to make a downward ECG tracing. Can you guess what's going to happen with Y? Yeah, so when we look at Y actually flows again towards the negative electrode because that negative electrode is lower than the positive, and Y is flowing from top to bottom. So it's flowing towards the negative electrode, and so it too is going to displace itself downward. And in fact, if you look at a normal electrocardiogram, this is what you're going to see, is a QRS complex that looks like the sum of these two negative downward deflections, and so the whole QRS is going to be downwards in lead AVR. All right, so if you need to pause for a moment and wrap your head around that, please do, but I'm going to get you to try and work this out on your own and answer a question that will show if you really got this. So here is a relatively normal ECG, and I want you to look at leads 2 and leads 3. In the ECG, both of them are upright, but lead 2 is quite a bit larger than lead 3, meaning the QRS complex is quite a bit larger in an upright direction than lead 3. I want you to pause this video for a moment, take a pen and paper, and see if you can figure out why that's the case using the same steps we just did. So I'm going to hold on for a moment here, give you a pause, and let you try and work through that. All right, let's walk through this a bit. So here we've got lead 2, and remember for lead 2, the positive electrode is always the groin. Remember, the groin is great. And we're going to break our QRS complex into its two vectors, X and Y. And so we're going to ask basically, what do you think X looks like? So X in this case is flowing towards the positive pole, and so you would think that X is going to have a positive deflection on the ECG. Let's look at Y. Y is flowing downwards, and downwards is towards the positive pole on lead 2, so you're going to expect a positive deflection for the Y. So to get what you're going to see on lead 2, you're going to add these two up, right? So two upward deflections like that is going to make slide 27. So to get lead 2, we are simply going to add X and Y together. Let's assume that X is maybe 3 ECG blocks high and Y is 2 ECG blocks high. If you add those together, you get something that is 5 ECG blocks high, 3 plus 2.
And so you get a fairly large positive deflection in lead 2, say 5 ECG blocks high. Now let's look at this in terms of lead 3. So lead 3, remember, runs from the left arm to the groin, or left leg if you like. And the QRS vector is basically the same. So what do you think X is going to look like? Well, in this case, X actually runs away from the positive electrode, right? It runs from the positive to the negative. And so we're going to expect there to be a small downwards deflection. Now note this is small because actually lead 3 runs mostly downhill as opposed to right to left. So you get a small deflection there. And when we look at Y, basically we're going to get a fairly large deflection upwards because Y actually runs from the negative to the positive lead. So you're going to get a large deflection upwards. And if you add these two together, you get an upwards pointed lead, but basically it's smaller because you have a small downward deflection and a large upward deflection. And in fact, that's what we see in a normal ECG, is lead 2, which is very much in line with the QRS complex, is quite upright and quite large, where lead 3 is partly in line with that. We often see an upright complex, but much lower amplitude than the 2. So that's it for this lesson. We've talked about how you describe a vector and what that is in terms of our QRS complex and basically the properties of electrocardiography. And we've discussed how that changes the size and tracings on our ECG. And this is going to be quite relevant as we get into the next discussion a bit on the QRS and its stages of depolarization, and also very relative when we get into bundle branch blocks. So thanks for hanging in, and we'll see you on the next lecture.